Okay, so moving on to Chapter 7, Sexual Problems and Solutions. Before we begin discussing sexual disorders, I wanted to give you an overview of how the autonomic nervous system works. So this kind of puts together the biology and the psychology of what's going on here. So we have two basic components of our autonomic nervous systems. We have the sympathetic nervous system that prepares us for a fight or a flight, and then we have the parasympathetic nervous system that calms us down and allows us to return to our normal resting state. And as you go down the list of things that are affected by the two systems, you'll notice that, for example, the sympathetic nervous system dilates your pupils. The parasympathetic nervous system constricts them. So they sort of, work in opposition. During sexual arousal, the sympathetic nervous system is working. So your pupils dilate when you become sexually aroused. You start to breathe more shallowly. Your heart rate accelerates. You start to sweat. You might get sweaty palms or actually sweaty armpits, things like that. As we go down the list, we see the bladder is at the bottom, and it says inhibits voiding. One thing that happens when we become aroused is that we're less likely to urinate, and in fact, urination becomes impossible at one point during arousal. Then we have at the very bottom the female reproductive organs, and we have the male reproductive organs, and you see that orgasm is stimulated by the sympathetic nervous system. What's interesting is that erection is triggered by the parasympathetic nervous system. So there has to be a certain amount of not being under threat or fear that is being accompanied by being aroused that'll allow for erection. So that's what's going on with an autonomic nervous system. And I think you're going to see why it was really important to mention this as we go on through these different disorders. So we're going to start with the problems that affect men. In my reading on the internet about sexual dysfunctions, I noticed that there were a lot of women's web pages that commented on the fact that there were a lot more treatments for male sexual dysfunction than there are for female sexual dysfunction. And that's actually objectively true, but it's really misleading because there are more treatments for male disorders, in large part because there are way more male disorders. The male reproductive tract has to work really well and perfectly in order to achieve erection, maintain erection, and achieve orgasm when the man wants to. So there are a lot of biological, functional things that have to happen for a man to function sexually, whereas for women the biggest problem tends to have to do with desire disorders, which men also suffer from. So men have the same things that women have plus more. There's only one disorder that I'm going to talk about that only affects women, and a lot of disorders I'm going to talk about that only affect men. So let's get started. Okay, premature ejaculation. This is the most common male dysfunction, or at least it's the one that men complain to their doctors about the most often. So it's at least the one that we know about the most. So what is premature ejaculation? Well, it depends on who you ask. Masters and Johnson said that it's the inability to control ejaculation long enough to satisfy your partner 50% of the time. If you recall back to the chapter we just finished, most women aren't satisfied through coitus with their male partners, and so this is kind of a harsh criteria that Masters and Johnson set up, because most women probably aren't going to achieve orgasm no matter how long their male partner can go. So Kaplan, if you recall, Kaplan provided an alternative sexual response model. Kaplan suggested that we should just call it premature ejaculation if the man feels like he does not have voluntary control over when he ejaculates, so he can't do anything to delay the onset of ejaculation. I tend to favor the Kaplan definition personally because it's a little bit less dependent on your partner. I mean, a man who's by himself might be dissatisfied with how abruptly his masturbation sessions end. So I mean, it doesn't require a partner in the Kaplan definition. What causes premature ejaculation? Well, all this data is going to come from the Mayo Clinic, and I got a lot of my information in this chapter from the Mayo Clinic, so we would have like good medical data. So causes? Well, we have psychological causes and we have biological causes. Psychologically, one theory is that we can develop habits earlier in life that cause an association between any kind of sexual arousal and then ejaculation pretty quickly thereafter. So if you learn that habit, you have to unlearn the habit. Actually, that's kind of a good cause, because if you can learn something, you can unlearn it. And so it should be really treatable. Now, why would you learn this pattern? Well, maybe when you were littler, you didn't have privacy. When you were younger, you didn't have privacy to masturbate when you wanted to or something. And so you had to rush. So rushing so that you don't get caught by your sibling, or maybe the only place where you could get any alone time was the bathroom, and you knew that somebody pretty quickly was going to come knock on the bathroom because it's the only bathroom in the house. Things like that. So if you've kind of learned to rush, if you rush because you really feel like bad about masturbating and you feel like you shouldn't be doing it, you might just rush to sort of get it over with so you can feel better but not really enjoy it. Another psychological cause of premature ejaculation is going to be relationship issues, and you're going to notice this is on a lot of lists of psychological causes of pretty much everything, because if the relationship is having trouble, a lot of times it'll manifest itself in sexual dysfunction. It could be that the person's feeling anxious about their performance, and so they may be unable to enjoy the experience and are instead wrapped up in anxiety. And anxiety can trigger the autonomic nervous system to kick in and make you feel like you're under pressure and cause ejaculation. Now, biologically, there are some possible physical causes, like abnormal hormone levels, if there isn't enough testosterone. If there's too much prolactin present, or vasopressin, or oxytocin, these hormones can alter the way that the male reproductive tract responds. Neurotransmitter levels like serotonin and endorphins can affect the way that the body responds to the messages coming out of the brain during autonomic nervous system arousal. So ejaculatory reflex, it's possible that the system that is set up in the male reproductive tract is misfiring, and the ejaculatory reflex is responding to the wrong stimulation. Thyroid problems can cause premature ejaculation, believe it or not, or inflammation or infection of the prostate or the urethra. So things going wrong in the male reproductive tract can cause premature ejaculation. It could be that a person has just inherited like hypersensitivity in the genitals, or ejaculatory reflex patterns, and it's just that's how they were designed. It could be that they've got nerve damage that's making them overly sensitive, or the link between what the brain is telling the body to do is somehow altered. So, I mean, there are a lot of causes that could be biological. The good news is it's mostly never biological. It's almost always psychological, and that's kind of good news, because premature ejaculation is pretty reasonably easily treated. So it may be the most common disorder, but it's also one of the more treatable disorders. So how do we treat? Well, psychologically, what we'll focus on is really associations. So you can use the squeeze technique, where the man is instructed to masturbate. You'll notice this looks like a female hand, so you could do it with a partner also. But so you become aroused, and then periodically you stop what you're doing and you squeeze just at the base of the head of the penis. You'll notice it's gently with her thumb and her two first fingers. You don't, squeeze like you're just trying to, squeeze all the blood out of it. It's sort of a little reminder. It's like sort of, okay, relax. Don't get too aroused. Let's take this slowly. And then you start over again with your activity. That part's called the stop-start technique. So you start sexual activity and then you stop. Maybe you apply a squeeze, maybe not, but then you resume sexual activity when that feeling of getting too aroused is over with. And so you keep doing that, alternating, stopping and starting, maybe implementing the squeeze technique as well. And then ultimately what you're hoping to do is break the association between like just sort of this climb towards ejaculatory inevitability. Another technique that's going to come up in every single disorder that we talk about is sensate focus. I provided a link in the modules so you can watch a little video about how this is actually done. It's pretty corny looking, but it really is accurate for what couples who are having any sexual dysfunction or lack of satisfaction can implement it. It doesn't even have to be a dysfunction. Sensate focus can really enhance healthy sexual functioning. The basic idea was introduced by Masters and Johnson, and the idea is that you're supposed to focus on the sensations that you're enjoying during sex rather than thinking about anything else. Performance, completion, shortcomings. You're supposed to focus on the sensations and just get lost in it. One theory of sexual disorders is that as we age, we start to get sort of goal-oriented. I keep using that phrase in these lectures, but we start to get a little goal-oriented about our sexual behavior, sometimes a little routinized. And so what sensate focus does is takes us back to when sex was new, and you could make out for hours and hours and hours and not expect to ever actually have any more elaborate sexual contact, that kind of thing, so you can just enjoy the sensations. So you can watch the video to see how to implement. Now, biological treatments, I first off have to mention that there are medications that can work on the hormone imbalances that might be present, the neurotransmitter imbalances that might be present. I would not recommend weird ones that you find on the internet. Usually you're going to need something prescription that would actually work. I liked this particular ad because it's cleverly called Delay. And I always like a nice medication that has a header that just names the disorder, Premature Ejaculation Medicine. That sounds pretty accurate. And if you go through what it does, it's 100% natural. Who knows what's in there, right? It acts through the neuroendocrine pathway. Okay, that sounds pretty sciencey. That might be okay, right? Non-hormonal herbal therapy. So obviously it's not going to be working on the endocrine pathway because endocrine system balances your hormones. Okay. Acts on the high centers of emotion in the brain. Well, the emotional centers are in the limbic system, so that would be more the middle of the brain. I'm not sure what they're talking about. Acts locally on the sex organs. What are you talking about? I don't know what they're talking about. And then regulates the process of ejaculation. I would not trust this medication. I would be looking for something more FDA tested if I wanted medication to treat my premature ejaculation. And that's true for any medication that we're talking about. There are topical anesthetics that a person, if your problem is that you're overly sensitive, then something like this might, reduce sensitivity. But like I said before, the goal shouldn't be to sort of take your mind off of what you're doing. So topical anesthetics would only be used if you actually know that your problem is that you're overly sensitive, and even the smallest amount of touch is overly stimulating. Antidepressants are medications that are often prescribed for people with premature ejaculation because premature ejaculation can be a symptom of anxiety, and antidepressants treat anxiety. And then we also have medications that are for erection that can also delay the onset of ejaculation. A lot of people are not aware that Viagra and Cialis and Levitra, they work by preventing blood from exiting the penis. And if you have a healthy penis, you would not want to add this medication on top of what's already going on with your healthy penis, because you can end up with the blood being unable to leave the penis for like 4 hours or more, and then you end up having to go to the hospital and have it drained with a needle, and that does not sound like anything most people want to do. So Viagra and these things are not for healthy functioning penises, and they should only be used if they've been prescribed. Erectile dysfunction used to be called impotence. But it was considered to be an offensive term because im means no and potence means strength, and that's pretty rude to tell a person that just because they can't get an erection they have no strength. So they changed it to erectile dysfunction. And the definition is the inability to have or to maintain an erection long enough for penetration. So some people have the ability to masturbate but can't have sex with a partner. They can't maintain an erection long enough for that. And so there are different kinds of what they call ED on the ads, right? So some people can't ever have an erection ever. Some can have erections in certain circumstances, and some have And then, the typical man has the ability to have an erection across situations and like that. So, some people have transient impotence. About 50% of men report having had an experience of what we call transient impotence. This oftentimes happens when you've taken some kind of medication or drug that interferes with erection. Alcohol is one of those drugs that can cause transient impotence. It's not real impotence like this ongoing problem where you can't have or maintain an erection. It's like while I was under the influence of too much alcohol, I couldn't get an erection. The treatment is, well, don't drink that much, right? Certain prescription medications interfere with erection, and the street drug ecstasy definitely does. And some kids at raves have been known to try and combat that side effect by taking Viagra and ecstasy at the same time, and that has killed people at raves from the blood pressure that raises that ecstasy gives, combined with the blood pressure trapping that goes on with Viagra, and kids have died from that. And then also mental state can cause transient impotence. If you have a person who's really super tired, or they're really anxious about something, or they're under a lot of stress, they may have an inability to have an orgasm. Because remember that autonomic nervous system, for the sympathetic nervous system to be able to kick in and for the parasympathetic nervous system to be able to cause erection, you need to not be experiencing anxiety. You need to not be experiencing stress. And of course, being tired is going to make pretty much all of our bodies not work correctly, let alone the penis. We call it transient because it doesn't happen frequently, or it happens maybe one time and never again. Where it can become a problem is if a person becomes convinced that, oh no, this is the beginning, and they're completely under stress that it's going to happen again. And they're completely under stress that it's going to happen again. And next thing you know, they make it happen. So I always like to really spend a bit of time talking about this so that men realize that one bout after a party or something like that does not mean that this is the beginning of erectile dysfunction for the rest of your life. Now I have this video from this ad from Viagra that I zoomed in and caught this one little part because she says out loud that 52% of men respond having some degree of erectile dysfunction. And when I heard that the first time, I was like, what are you talking about, woman? So I found the ad, I found the little caption, the frame that has the caption on it, and found that she was referring to the Massachusetts male aging study. There were 1,290 respondents in that study, and I was like, okay, I'm going to have to look up what it really was. So I found the original study, and this is what I talked about being critical thinkers of information that you hear. If it sounds wrong, take a second. You guys have Google it, and I found this no problem. And what they reported was that they administered a self-administered sexual activity questionnaire to characterize erectile potency, and it says the combined prevalence of minimal, moderate, and complete impotence was 52%. So if you take all of that together, 52%, the prevalence of complete impotence tripled from 5% to 15% between the ages of 40 and 70 years. So when she says 52% of men reported some degree of erectile dysfunction, I don't think they were hoping that the listener would focus on the word some degree, right? I think they were hoping that the listener would focus on 52% erectile dysfunction and come to the conclusion that this is really common. It's probably going to happen to you, that you better get yourself some Viagra and keep it, because it's gonna happen. If you're over 40, you're gonna get it, is what I think they want people to conclude. But if you look at the study, you realize complete impotence, where you can't have an erection at all, which is our definition of impotence in this section, goes from 5% at the age of 40. 5% of men complain of it at age of 40. By age 70, only 15% are complaining of it. So that's still a very small percentage of men who are experiencing complete. Now minimal, that means it happens sometimes, but most of the time it doesn't. Moderate, it's happening sort of as often as it is not happening. Okay, we're going to be getting closer to 52% if we lump all those people together. But if we take out the minimals, if you look at this study, if you take out the minimals, the people who it happens rarely, and you just focus in on the people who are moderate and complete, you're looking at something like 25% of men by the age of 70. So they're overstating it, and it's just really a good example of how you need to be really careful and a critical thinker when processing information. So what does cause erectile dysfunction? Well, as you remember from the Kinsey survey that we took at the beginning of class, I mentioned that, well, it depends on who you are. If you're a psychologist, you think that the causes are going to be psychological, and if you're a medical doctor, you're going to think they're biological. So, what psychological things? Relationship issues. A lot of times when men are having difficulty with erection while having sex with their partner, but they don't have difficulty with erection when masturbating or when having sex with someone else, we can probably track it back to something's going wrong in the relationship. This is very situational erectile dysfunction, and something needs to be fixed about the relationship. Depression can cause erectile dysfunction. It's actually one of the symptoms of depression, to lose interest in sexual behavior. So depression can cause impotence. And then anxiety. Of course, if you're anxious about stuff that has nothing to do with a relationship, it's still going to have an effect on the way that your autonomic nervous system is functioning. So, psychological factors can impact the biology of the man. Now, biologically, cardiovascular disease can trigger erectile dysfunction. If you don't have enough blood getting through the heart and through the blood vessels in general, they aren't going to make it to the penis either. It's considered an extremity, so you're going to have difficulty getting enough blood into the penis to cause an erection. So what do we mean by cardiovascular disease? It could be actual heart disease. It could be high blood pressure. It could be clogged arteries, even in extremities of the body. It could be too high of cholesterol. Chronic diseases like diabetes can cause erectile dysfunction. Multiple sclerosis, which is a disorder where your axons are getting rigid periodically in your brain, and you can't send messages out to the extremities of your body. And then Parkinson's disease can cause impotence. Substance abuse, tobacco use can trigger erectile dysfunction, and partly because it can cause clogged arteries, high blood pressure, and other things. Alcoholism, obesity can cause erectile dysfunction. I guess obesity is not technically a substance, but I guess maybe if the substance you abuse was food, I don't know why I put it on that list. I don't know why I put that there. And then nerve damage. There are men who, for example, ride their bike a lot, and they've compressed the nerves that feed their penis and actually develop erectile dysfunction as a result. Having injuries to the penis, things like that can cause erectile dysfunction. So what can we do? Well, psychologically, we're going to look at sensate focus. If the problem is, at the heart of it is relationship issues, and if at the heart of it is, goal orientation and things like that, sensate focus will help to treat that. And then couples therapy, especially if you've got some aspects of depression and some relationship issues going on, couples therapy can help us to sort out which parts are due to the depression, which parts are due to lack of desire, and different kinds of things. So couples therapy can sort these things out, may come to the conclusion that, part of it is psychological, but part of it's biological. And so maybe we can treat the biology and we can treat the psychology at the same time. So there are oral medications for erectile dysfunction that can help to improve blood flow, like Viagra, Cialis, Levitra. So those are all what we call nitric oxide enhancers. You can also take testosterone replacement. Sometimes men, as they age, will start to produce less testosterone or become insensitive to their testosterone. So we may have to focus in on the testosterone. There are all sorts of ways these days to deliver testosterone if a person needs extra. The key thing is it needs to be medically prescribed and not, crazy stuff off the internet that's so available these days. The only way to get actual biologically equivalent testosterone is from your medical doctor. There's this nice video of how to do penile injections. There's actually a medication that can be injected into the corpora cavernosa of the penis that causes the vasodilation that allows all the blood to come flowing in. So that's a treatment that's available. There's also urethral suppositories that you can insert into the urethra, and that disseminates that same kind of vasodilator into the corpora cavernosa. And then there are penis pumps that you can place over the penis, and it suctions on up against your stomach, and you pump the machine and it pulls blood into the penis, and then this little therapy pump puts a ring around the base of the penis, and then you remove the pump, and that ring keeps the blood in the penis. Usually this would be prescribed if you're having difficulty with the valve that normally shuts and keeps the blood in the penis. This is a good time to mention penises should never have cock rings on the bottom of them if, at the base of them, if this is a normal, healthy, functioning penis. Cock rings can, as the penis fills with blood, can get embedded in the flesh and you can't get them back off. And then again, it's time for a nice trip to the ER to have that blood sucked out with syringes. Cock rings are not necessary for a normal, healthy, functioning penis. It's for people who have trouble with keeping the blood in their penis. And then my final example is penile implants. Actually, yeah, I think this is my last one. Penile implants are either the penile implants can either come in the form of semi-rigid tubes that are implanted into the corpora cavernosa, and so then you end up with a penis that's always just a little bit semi-erect. It's never as rigid probably as it would be with a regular functioning penis, and it's never quite as flaccid as it would be with a regular functioning penis. It's always sort of at the semi-erect state. Other penile implants are sort of empty tubes, kind of, that can be implanted into the corpora cavernosa, and then there's this like bulb of oil that's stored in a little cylinder that's in the testicles that's held in the scrotum, and you squeeze the tube and it moves the oil into the tubes that are in the corpora cavernosa, and that causes an erection. And then after sex, then you would twist the receptacle in the scrotum, and it lets the oil back out, and then the erection goes away. So they've got a lot of new ways to cause erections, and including you might need blood vessel surgery if you've got blocked arteries feeding the penis. So there are a lot of treatments, and this is one of those things that females oftentimes will complain about, that look at all these treatments for erectile dysfunction, and there's so little available for lack of desire or things like that women suffer from. But these are all different kinds of ways of trying to achieve the same goal, and some people will respond to oral medication and some don't. So then some will respond to penile injections and some don't, and then so we can kind of move up the ladder of more and more invasive. And part of the reason why this is considered kind of an important factor is because their partner is dissatisfied also oftentimes when they can't have an erection, and so it impacts the relationship and stuff. So, but so does lack of desire. So we'll talk about that in another segment. In fact, let's go ahead and take a break here, and we will talk about delayed ejaculation in the next segment.